Hello and welcome to Chairside Live. I'm your host, Megan Strong. Thanks so much for being with us today. In this episode, Dr. Anna Maria Murashon is restoring a patient's smile after he suffered tooth loss and buccal plate resorption. The patient declined implant treatment, so Dr. Murashon turns to a 3-unit Bruxer Esthetic bridge, as well as a couple of Bruxer Esthetic crowns and a veneer to offer this patient a brand new reason to smile. Dr. Murashon, over to you.
My patient Anthony, who is 52 years old, shared with me his joy of being a father to a soon-to-be high school undergraduate. Hoping to rejuvenate his smile in time to celebrate his daughter's commencement, Anthony preferred a bridge to treat his missing lateral rather than a lengthy implant treatment. As I assessed the condition of his teeth, I could see the issues were far more substantial than just an aesthetic improvement. My immediate concern was the extensive anterior tooth destruction. The loss of teeth has altered his occlusion relationships. Occlusion interferences have restricted the functional movement of the jaw and have severely damaged the tooth structure. When studying the etiology of Anthony's teeth, it was evident that he had lost canine guidance and posterior disclusion. Movement of the mandible in protrusion was damaging the incisal edges. The longer the current situation continued, the greater the risk for full destruction of the teeth increased. To transform Anthony's smile, I plan to rehabilitate his occlusion starting with an interim composite build-up prototype that effectively filled the edentulous space of number 7 and lengthened the worn-out incisal edges of 6, 8, and 9, re-establishing the canine and protrusive guidance. Subsequently, appointments were to prepare and deliver 3-unit bridges for teeth 2 to 4 and 13 to 14. Now that the posterior bridges were seated and the interim trial period completed, we will start with the removal of the composite prototype and focus today's presentation on the Bruxer aesthetic restorations used for the anterior zone. Teeth were prepared from 5 through 11, 6 to 8 to receive a 3-unit Bruxer aesthetic bridge, crowns for teeth 9 and 10, and Vivaneer conventional prep Bruxer aesthetic veneers for teeth 5 and 11. I start by placing depth cuts to ensure that the minimum thickness requirements for the restorations fabricated in Bruxer aesthetic material were met. Ideally, the lab prefers 1.25 mm incisal reduction or a minimum of 0.7 mm. After the impression was taken, it was time to deliver the Biotemp CAD provisionals. Here is a useful tip. When handling the lab-made biotemps, to aid in proper orientation during reline, I recommend the use of the fast stent that the lab provides. Without it, since the Biotemp CAD temporaries are very shallow, there is always a risk of creating protruded temporaries that will look procline or bulky if oriented incorrectly during the reline. When trimming off the excess, there should be enough room for the interproximal papilla to avoid any tissue impingement or black triangles at the final delivery. Following a 2-week period, the 7-unit provisional was removed. The preps were cleaned of temporary cement and pumice prior to try-in. The final restorations were evaluated for marginal fit, aesthetic, occlusion, and phonetics. Since the technician followed the guidelines of the provisional restorations, no contact or occlusion adjustments were necessary at this stage. The teeth were prepared for final sit using Verioling Aesthetic dual cure luting cement. The etch step is optional, but to increase the bonding strength, the preps were etched. Here, the preparations are conditioned with adhesive after the application of the etch step. Once the preparations were treated and teeth were isolated with Teflon, we moved to the pre-treatment of the intaglio surface of zirconia. To clean, we can scrub it with IvoClean or sandblast it again with aluminum oxide. This step is not to be confused with silica-embedded aluminum oxide, also known as coated sand, which you can see here is sandblasted onto the zirconia surface of 5, and 11 as an option to provide the highest bonding strength for zirconia veneers. You can complete this step chairside, or it can be provided by the lab. Here's another tip. I find it easier when Will, my assistant, preloads the veneers and passes it on a surgical suction tip. Carefully not to place the vacuum tip too close to the edges of the veneer so it will not suction the cement while seating. Then I will ensure a full seat of the veneers using wooden sticks before polymerization. After removing all the excess, one last polymerization stage is performed after the application of the oxygen-inhibiting glycerin gel. This clinical case presentation has demonstrated how Broxer Aesthetic was successfully used as a treatment modality to restore severely worn dentition, promising a strong alternative for rehabilitation when canine guidance and protrusion must be reestablished. By combining aesthetics with function, the new highly translucent Broxer Aesthetic has a flexure strength of 870 megapascals, and it has the durability to be used for bridge work on the anterior region of the mouth. These Broxer Aesthetic restorations dramatically renew Anthony's smile, from reconstructing healthy function to providing a natural appearance that looks outstanding from every angle. The proven durability and natural appearance of Broxer Aesthetic zirconia were essential to the success of this case, giving Anthony a spectacular new smile designed to last for years